sir. Good evening.
Hello, good evening.
Start first.
Start the recording. Yes, share the introductory slides, please. Please start the introduction. Good evening, all of you. Welcome to this 255th edition of Thursday Musings. Uh, we will today talk about how to handle various medications when a patient is going into operation. What is the pre and post-op precautions, procedures. This session will be recorded. It will be put on the YouTube channel. The questions are invited in the chat box, so you can type the questions as the program goes on, and later they will be put to the presenter. Everyone will be on mute mode because there are a large number of participants. So next slide, please. I'm starting the session in absence of Professor Dr. Tufan Pati sir. He is the chairman of this program. He has some engagement, family engagement today, so he's not there today. Next slide. The moderators will be Dr. Amrit Patijoshi. Next slide. Myself, Dr. Aleem Siddiqui from Lucknow. Next slide. Dr. Shobhit Garg from Dehradun. He may be joining late today. And next slide. Dr. Vishal Chhabra from Delhi. These will be the moderators of the session. Next slide, please. Coming to the chairpersons. So today's chairperson is Dr. Lalit Batra. We all know him, but still we have to formally introduce him. He's Senior Professor and Superintendent, Department of Psychiatry, SMS Medical College. He has more than 20 publications in journals of repute. He has authored 3 textbooks in psychiatry, a regular writer of articles in popular newspapers, recipient of Bakshi Award 91, Marfatia Award for Scientific Paper in 1994, Young Psychiatrist Fellowship Award at 11th World Conference of WPA in 1999 in Germany, past President and Secretary of Indian Psychiatric Society North Zone, Rajasthan branch, and council member of Indian Psychiatric Society. Welcome, sir. Welcome to the webinar. Next slide. The second chairperson is Dr. Arun Nagasundaram. He is MBBS from Bangalore Medical College, MD Psychiatry from BGM Medical College, Ahmedabad, and DMD Psychiatry also. He's a consultant psychiatrist and director at Atma Hospitals for last 19 years. He is a PG teacher in DMD Psychiatry. He's past treasurer of IPS South Zone branch. He's past treasurer of Indian Psychiatric Society, Tamil Nadu chapter. Currently, Honorary General Secretary, IPS Tamil Nadu chapter, consultant psychiatrist, Trust Shantivanam Rehab Home for homeless persons with mental illness, areas of interest, rehabilitation, art, and psychiatry. So welcome, chairpersons. This meeting is now under your command. Over to you for further proceedings. The chairpersons, please. One may introduce the speaker, other about the topic.
So, shall I start, sir?
Yes,
good evening. Good evening. It's a privilege and honor to be as a chairperson for a very senior and foremost psychiatrist of our IPS. Happy to introduce Dr. Professor Sandeep Grover. He's a professor at PGI Chandigarh, and his areas of interest are CL psychiatry, emergency psychiatry, geriatric psychiatry, and severe mental disorders and psychopharmacology. More than 980 publications in peer-reviewed journals and 100 book chapters, edited 7 books, and his high index is 76, and citations around 26,780. So it's very huge, and I think he'll be the first person ranking in such citations and publications in all over India. Total awards is 74, including various awards from all over India and across the world. Awarded thrice in Indian Council of Medical Research, listed as a top 22% researchers by Stanford University based on lifetime research output. So a person who would be very apt for such a precise topic, and we all know that we will be called for various hospitals as a liaison. As a private practitioner, I've been called to the neighboring hospitals where patients will be awaiting for a surgery or post-surgery. And so we have to be very careful in selecting the antipsychotic, though the physicians or the surgeon will know what antipsychotic they can prescribe, but still not just antipsychotics, psychotropics, but still they ask for our opinion. Hence, carefully selecting the psychotropics, and um, we have to be very cautious in adding also. So here we have a speaker who will throw us light on this topic. Over to my another coach chairperson to introduce the topic, sir. Thank you.
Batra sir, are you there? Because I don't see his
I
profile.
can't see him. I can't see him. Maybe he's disconnected.
He was just there. I think he's disconnected.
Yeah, he's
So he's
come.
not.
He's
Now
come.
back.
He's come. Hi. Dr. Lalit?
Lalit sir, if you can unmute and talk about the topic. His mic is not there. Sir, you have to unmute.
Okay, now fine.
Yes, sir.
Very well.
Fine. So, I start now.
Yes,
Yes,
sir.
sir.
Okay. Thank you, and good evening, dear friends. And it is basically my privilege to be here to welcome you all on this important session of Thursday Musing. The topic which you already which you already know, how to handle the various psychotropics in pre and post the operative patients. Basically, this is a topic which sites at the crossroad of psychiatry, surgery, anesthesiology, and it is the one that challenges us in everyday practice. You know, we every day receive references from the hospitals, and we are coming across with all this. And with the rising prevalence of psychiatric morbidity and psychotropic prescriptions, it is now almost a rule rather than an exception, that most of the surgical patients, they are on antipsychotics and anxiolytics, or they are on mood stabilizers. So it has become very so the important question which inevitably arises, do we continue, do we taper, or stop medicine? So this is the common thing which they ask for whenever they are taking reference for this purpose. So each decisions, it carries a lot of implications, not just for the safety of anesthesiology or anesthesia or the surgical outcome, but also for the patient's psychiatric stability. So this session, I think today will going to be a master class on this art of balancing risks against the benefits. And when the goal is not only to prevent the complication, but it is also to ensure the continuity of psychiatric care and the overall the patient holistic care. So just to throw a light on this, probably today we are having a very distinguished speakers with many remarkable contribution in the psychiatry, in the field of psychiatry. So I request my other co-chairperson, Dr. Arun Kumar, to introduce our worthy speaker.
Sir, he has introduced. So
Okay.
I think we can now
Probably,
go to.
I was disconnected
Yes,
during that
yes,
time.
sir.
So probably so
So
that.
Sandeep sir, you can start now.
So Sandeep,
Thank
please
you.
start. Okay.
Thank- Yeah. Am I audible?
Yes, boss. You are.
Yeah. Thank you. At the outset, I would like to thank all the moderators and the chairperson of the Thursday Musing for inviting me to speak on this topic. And before I start my presentation, I would like to say that I don't have any conflict of interest when I'm discussing this area. And in terms of disclosures, I'll be using certain images and tables which are available on the websites or the internet, but the copyright of these are with the publishers and not with me. So these are not my copyrighted material in terms of using these tables and copyrights. So with this disclosures, let's move to the topic per se. So as the worthy chairperson said, I'm just rewording that a medical comorbidity in patients with mental disorders is a rule rather than exception. And with the increasing age, the prevalence and the number of medical comorbidities keeps on increasing. Hence, this need for surgical interventions also keeps on increasing as the age progresses, because more and more medical surgical complications of the problems start emerging in every human being. There's some problem why it's not moving. Yeah. So when we look at the perioperative period, we need to understand that, as the topic suggests, there could be a pre-operative period and there could be a post-operative period where the psychiatrist will be consulted for using or not using certain psychotropics. Now, here we need to understand that there are a lot of variations here, and that you may be called to decide about whether a medication needs to be continued for a pre-existing mental disorder, or a person may be having substance withdrawal just close to the surgery, or a person may be having anxiety, insomnia, and delirium at close to the surgery, or you may be later called for restarting the medication. Now, the whole problem is this whole duration of so-called pre-operative period or the post-operative period can be so variable that it is very, very difficult to make any one kind of a recommendation. And at the same time, when we talk about operations, because the human body has so many organs and there are different kind of surgeries which happen, it is very, very difficult to make one single conclusion for all kind of surgeries. So we need to keep that in mind when we are trying to understand this topic, but I'll still try to put some kind of evidence which is available, and let's try to understand how it should work. And as I said, there are no clear guidelines that can be applied to all patients, all types of surgeries, all situations, and all the time frames. So this must be kept in mind when we are looking at this topic. So what we need to do, individualize the decision making for each patient whom you are considering. Take an informed decision in terms of, like, always involve the patient and the family wherever it is available to make a decision rather than you on your own making a decision. And cover yourself legally, because what happens that your medication is going to be continued, but somebody else is going to operate, somebody else is going to give anesthesia, and you may not have control over what is being documented, what is not being documented. And if a patient unfortunately has a negative outcome, it can be put on your psychotropic medication and it can indirectly again come back to you, have to take the responsibility of the negative outcome, and you may be unnecessarily dragged in the court. So keep that in mind, that it's not just simply just you can take a decision of writing or not writing. So it has a lot of implications. So let's first try to understand why it is risky to prescribe during the perioperative period. Because that's the most important thing, because there's a constant risk of physical decompensation. That person can walk into a surgery, very healthy kind of a person, he goes through the surgery and certain complications arise and suddenly he is into a multi-organ failure. So a very healthy person can go into multi-organ failure, or a person who was doing very bad can improve out of it. So there's a lot of variation going on there. Many of these patients may not be allowed to have oral intake, maybe for few days before the surgery or few days after the surgery. So you need to keep that in mind as well. And as I pointed out already, there are legal complications, and there could be drug-drug interaction, drug-disease interaction, and the decompensation. There are a lot of electrolyte imbalances. There will be a lot of fluid volume changes. The patients are at a risk of hypoxia and infection. So you need to remember these facts when you're trying to decide about prescribing and not prescribing, besides the surgery and anesthesia part of it. So whenever it comes to prescribing or deprescribing, intuitively, most of the psychiatrist and the surgeon will consider deprescribing rather than prescribing. However, what it is important, or it is important to understand, is it necessary to deprescribe in all the patient, and is it possible in all the patient? It may not be also possible, because you may be called just few minutes before the surgery and you have to take a decision. So that is where the whole problem arises. So just looking at the things, that whether we need to prescribe or deprescribe, we need to keep these facts in mind. And when we look at the research evidence, there are no RCTs on this topic to make any conclusion or any guidelines, or you don't have a very high level of evidence to make any conclusions. So always there's a clinical dilemma about prescribing or deprescribing. And so with this background, let's look at the perioperative period. What happens and what is the kind of evidence we have. So there could be three situations: deprescribe, not to prescribe if you are called in terms of starting a new medication, or to prescribe. So let's look at the deprescription, because this is something which is very controversial and many people have a confusion about this. So always the question is, if you have to decide about deprescribing, in whom to stop, what to stop, when to stop, why to stop, how to stop, are the certain questions which comes to everybody's mind. And then the other question is, what if I cannot stop? Means you are called very close to the surgery and there is no time to stop. So this is something which needs to be kept in mind and we need to understand. So what are the factors which determine deprescribing, and what are the factors which should be considered while considering deprescribing? That amount of time you have in hand, the type of surgery the person is supposed to go, type of anesthesia the person is going to receive, the physical health status of the person, the risk of relapse of mental illness, or the risk of withdrawal from once you stop the psychotropics. It could be benzodiazepine, it could be antipsychotics, it could be antidepressant, and what are the risk of continuing. So these all factors must be considered before you take a informed decision. Now, as far as the time in hand is concerned, depending on the acuity of the surgery, we all understand whether it is an elective surgery or an emergency surgery. In elective surgery, you have time to stop, and that is where no issues. But for urgent surgery, you don't have time, and the risk of continuing medication has to be considered what is going to happen. So when we look at the various organ kind of surgeries or what is going to happen, we need to also take into account, although the person may be undergoing surgery in a different organ, but let's say somebody is undergoing neurosurgery, he may still have nil oral, or can also have a hepatic comorbidity or cardiac comorbidity, or there could be renal comorbidities which can influence the medication clearance. So this is where you need to keep in mind, it's not just evaluating the surgery, but you're evaluating the person per se. So when we look at the recommendations for stopping, what are the recommendations? Because we have different kind of recommendations and there is no single consensus on it. So in general, if you look at, as per one of the recommendation, TCS needs to be discontinued. MAO needs to be discontinued about 2 weeks before the surgery, that is irreversible MAO. And rest of the medications can be continued. Additionally, sorry, I'm missing out on lithium, that it needs to be discontinued 24 hours before surgery. Rest of the medications can be continued. But this is something you have to understand, that there are also things which are listed as perioperative concerns, and there are also the features of withdrawal symptoms which can happen. We need to keep that in mind when we are talking about continuing or discontinuing. Now, this is one of the recent consensus guidelines which has come in terms of the perioperative management. This is from the Mayo Clinic, and this whole guideline was based on a Delphi method, where the experts were invited to participate and they were given different questions to rate or different medications to rate, that can the person take it, or do you need to hold it, or it depends on the clinical circumstances. And for each, the rating was done on a 0 to 9 point, and the consensus was reached that if anybody for any drug, the consensus of more than 7 was considered, it was considered there's a lot of consensus to use or not to use. So let's look at what are the recommendations from this. So very simply, if you want to understand it, if you can look at this table, there are issues with regard to only the MAO inhibitors, lithium. These are the two drugs which are in this category where it is recommended to discontinue. And for other drugs, all the drugs can be continued per orally till the day of surgery. Now, when it comes to the so-called methylphenidate, amphetamine, amphetamine, these are the only drugs which cannot be given on the day of surgery. Rest can be given on the day of surgery as well. Now, the other recommendation, the simpler one, if you look at here, almost they are similar, but some of the recommendations suggest that antidepressant needs to be stopped about 7 to 10 days before the surgery. And in terms of antipsychotic, there is clear recommendation for clozapine to be withheld 12 hours before surgery. And anticholinergic medication, to stop or not stop will depend on other overall risk factors for developing delirium. So if you look at all these three recommendations, what we can say that Other antipsychotics, mood stabilizers, benzodiazepine, you can continue till the day of surgery. There is no confusion. Other antipsychotic, I'm saying, other than clozapine. So when we say you can continue, you need to individualize. And for elective surgery, what if the risk of relapse is high? So for the drugs and other things where you want to individualize, so the individualization will come with the risk of relapse. So if you are deciding about stopping a medication, let's take the example of lithium, you need to go for a slow taper, take a benzodiazepine or antipsychotic cover, and reinstitute the medication as early as possible when the patient is hemodynamically stable. Now, for elective surgery, when there is no time, when I say that you have been called on the day of surgery or a previous day of surgery, and considering the medication's half-life and other things, you are not in a position to stop the medication. Only what you can do is withhold one dose of medication, but that does not prevent for the complications to arise. So that needs to be understood. So in that case, there is a need to have a proper discussion with anesthetist and the surgeon. And the first guiding point here is the type of anesthesia and surgery. So what, as a psychiatrist, we need to understand about anesthesia and surgery? Let's look at the next few slides. So we all understand anesthesia as general anesthesia, local anesthesia, regional, or monitor anesthesia. So here, the simpler thing to understand that the choice of anesthesia often depends on the overall patient's health, type of surgery, the surgeon and anesthetist, their own recommendations. And this prescription is a consideration when the GA is being considered. For other kind of anesthesia, you don't have to worry. You don't have to go for a D prescription. For example, some person who is undergoing, let's say, some kind of a orthopedic surgery, and it is to be done under spinal anesthesia. You don't have to worry about the prescription. Then you are very, very clear about, in terms of, from an anesthesia point of view, there's no need to discontinue the medication. But when the GA is to be considered, what are the factors which you need to look at as a psychiatrist before you decide about prescribing or de-prescribing? So here, from an anesthesia point of view, all patients who are supposed to undergo anesthesia, they are evaluated for their physical health status, and they are categorized into these 6 category of ASA 1 to ASA 6, basically depending on the severity of the physical illness. So here, the cause of concern arises when the patient is in the ASA category of 3 or 4, where you have to start worrying. Now, because why it is important? Because a person with ASA 3 and ASA 4 category have more risk of post-operative complication if there are intraoperative complication along with are arising. So per se preoperative ASA 3, 4 will increase the risk, and if there are combination of intraoperative and preoperative, there are further increase in the risk of complication. So that needs to be remembered. Now, what are the recommendations for ASA 1 and ASA 2? ASA 1 is healthy person who is non-smoker and no minimal alcohol, let's say an Indian woman, typical woman, I'll say that. And the ASA 2 will have those with mild diseases and so on. ASA 3 has people with substantial functional limitation. They have one or more moderate severe diseases, poorly controlled diabetes, hypertension, COPD, and so on. And ASA 4 will have that in recent last 3 months, there is an MI or a CV or so on. So if you understand these categorization, the simpler thing to understand is for ASA 1 and 2, all psychotropic medication can be continued. So if you are sitting in your outpatient, you receive a prescription from anesthetist asking you for a surgical clearance or to decide about psychotropics or not to continue or not to continue, or you're talking to an anesthetist, always ask what is the ASA category for the patient. So ASA 1, 2, continue. ASA 3, 4, decision making will be individualized. ASA 5, 6, stop all psychotropics. Because these patients are at a very high risk of medical complications, and you don't want to be blamed for anything which happens. And here the life is more important for the patient rather than just only controlling the psychiatric symptoms. But unfortunately, also we need to remember that most of the patients for whom psychiatrists are consulted belongs to categories 3 and 4, and all psychiatric patients who are on psychotropics are again categorized as category 3 and 4. So you'll very rarely have some patient with depression or anxiety belonging to category 1 or 2. So that needs to be kept in mind. That if you want to have a simpler rule to understand, all your patients are in ASA 3 and 4, so you have to individualize. So what does it require? It requires a very, very close collaboration between the psychiatrist, surgeon, and anesthetist, and we have to discuss the risk of continued use of medication. So what you can do, for example, when you don't have time and you don't, or when you don't want to deprescribe. Remember these two things. When you don't want to deprescribe or you don't have time to deprescribe, what you need to do? You need to try to control what should not be prescribed with ongoing psychotropic medication. That's the important basic thing which we need to understand. So here, for example, if you don't want to deprescribe SSRI or you are not able to deprescribe, what you need to be talking to your anesthetist and the surgeon colleagues. Tell them that this person are at an increased risk of so-called perioperative bleeding, serotonin syndrome, hyponatremia, other possible drug interactions, and the drug interaction can lead to decreased pain control with opioids, and that this also can increase the risk of delirium because of the hyponatremia and other factors which can come in together. So you have to decide. Abrupt interruption can also lead to discontinuation. So we have to balance this risk versus abrupt discontinuation, and this is the kind of discussion you need to have with the anesthetist and the surgeon. Now, there's a risk of perioperative bleeding. Again, if he asks what is the risk, how high is the risk of perioperative bleeding, again, you need to understand, depending on the serotonin transporter affinities, antidepressants are categorized into those with high affinity, intermediate, and low affinity. Those with high affinity are more likely to cause higher risk of bleeding. So if you look at from that point of view, fluoxetine, sertraline, and paroxetine have high affinity. So this is where you have to be more worried about. But citalopram, intermediate category, so not as bad as it. But for mirtazapine and some of the TCAs, the affinity is low, so you should not be worrying too much. And especially this worry comes in when you're the person who is going to be operated is a female, undergoing orthopedics and neurosurgeries, and patient is receiving NSAIDs and anticoagulants. So this is where again you start controlling the prescription of other medication. You start discussing that what can be stopped. So if you have decided to continue, always, like at the time of informed consent for the surgery, request the surgeon or the anesthetist to take an informed consent from the patient about this possible risk of bleeding, so that you are covered, they are covered. And they should be closely monitored. Blood grouping should be done. Baseline bleeding clotting time you need to have in hand, and extra blood if it is you are suspecting the person can have bleeding, you have a backup of the blood. Similarly, the risk of serotonin syndrome needs to be discussed. That serotonin syndrome can arise because of introduction of new concomitant medications. So what are the medications which can precipitate serotonin syndrome in a patient who was receiving SSRI or other antidepressant close to surgery? Are some of the opioids, antiemetic drugs, which are again very liberally used during the surgery, some of the antibiotics like linezolid, and some other agents like methylene blue, which may be used during close to the surgery or during the surgery, which all can precipitate the serotonin syndrome. Because I'm focusing only on the drugs which are going to be introduced close to the surgery. Or there could be introduction of other molecules which can inhibit the CYP3A or 2C19, something like ciprofloxacin, ritonavir, or fluconazole. So these drugs can again precipitate serotonin syndrome. So this needs to be kept in mind. So again, you need to closely monitor the patient. Renal function test to be monitored so that you know that how much the drug is getting cleared, and always tell the surgeons to avoid medication which can increase the risk of serotonin. Psychoeducate them what are the signs and symptoms of serotonin syndrome and what can be the possible antidote which they can use in terms of cyproheptadine, so that all of you are on the same page. Coming to hyponatremia, again, surgery per se is often a risk for hyponatremia. And there are other multiple, like when we are talking about a patient undergoing surgery, they may be having multiple comorbidities. So you need to know what kind of medical conditions can precipitate hyponatremia and what kind of concomitant medication can precipitate hyponatremia, and at the same time what are the factors which are associated with antidepressant or the psychotropic associated hyponatremia. So if you know those factors, your discussion with the anesthetists and surgeons becomes very, very easy, and that's where you can again discuss about what to prescribe and what not to prescribe. And so again, same sodium monitoring will be required, and the prescriptions needs to be controlled. The other issue is about the QTC prolongation. Now, again, we understand that we don't talk about QTC prolongation with antidepressant but we need to understand because escitalopram, citalopram are the most commonly prescribed antidepressants. So these people can be at a risk of QTC prolongation. Of course, we understand TCS and SNRIs like venlafaxine can lead to QTC prolongation. So again, very, very important to understand, have things in your hand ready. What are the medication which can increase the risk of QTC prolongation and how much you can control them, like which antibiotics not to prescribe, which antiemetics not to prescribe, which direct diuretics, proton pump blockers needs to be avoided. Because these are as I said, the proton pump blockers are the ones which are liberally used. So if you have that discussion with the anesthetist and surgeon, at least you have made them aware. If you are not having that discussion, you need to have these things in your hand so that when you are writing your notes, let's say in a CL psychiatric setup, you write that please avoid this medication because of these risks. So then you are covered. Whatever the outcome is, you may not be still held liable for that. So again, we need to continue monitoring the ECG and the electrolytes. For that, now the risk of continued use of clozapine, because this is something which is very, very tricky, that you have been called, patient was already on clozapine. What are the risks? You need to discuss about the risk of CNS and the respiratory depression, risk of hypotension, and how clozapine can interact with the different anesthetists and how the interaction can lead to either very high levels of clozapine or the aminoamides anesthetist, and there could be issues. There could be issues of QTC prolongation, and if you're deciding about sudden stoppage of clozapine, the patient is at a risk of anticholinergic syndrome. If you're continuing, and there could be risk of the venous thromboembolism. Then, in terms of GI surgery and other things, because of the different situations, the person can also, if the person has undergone some GI surgery, because of the continued use of clozapine, the patient is at a very high risk of post-operative ileus, and a combination of opioids and anticholinergic medication may actually make it worse. And also remember that at the time of surgery, the patient would have undergone cessation of smoking or reduction in smoking, so that can again increase the levels of clozapine levels. So these are the different risks which you need to discuss with the surgeons, and this needs to be taken into account while discussing with the family. So we need to be very, very clear about monitoring, and prophylactic laxatives may be considered in people who are very sensitive or susceptible to constipation, and we need to be having a very active surveillance for anticholinergic syndrome, and wherever possible and required clozapine levels needs to be done. Coming to lithium, again, narrow therapeutic index, and it can also lower the seizure threshold. That needs to be kept in mind. So what are the drugs which can increase the serum lithium levels? Those needs to be kept in mind, so that, and besides the drugs, something like febrile illness can further complicate the matter. And this, again, the issue of lithium becomes very important, especially in people who are, let's say, undergoing delivery, females especially. There will be a lot of fluid changes, fluid balance change. So there's a high risk of developing toxic level of serum lithiums. And lithium also increases the risk of serotonin syndrome, especially when it is used with other serotonergic drugs, not necessarily SSRIs. And it can also prolong the effect of the both depolarizing and non-depolarizing neuromuscular blocking agents. So it can prolong the recovery from anesthesia. And that if it is used with thiopentone, again, it can prolong the hypnotic effects, and it also can block the brainstem release of non-adrenaline and other amines, and it can decrease the anesthetic requirements. So there can be a lot of unpredictability when lithium is being continued. So closely monitor serum lithium levels, electrolytes for dehydration and fluid loss, and that needs to be discussed accordingly. So in summary, if you have no time to deprescribe, try to control the prescription of agents that do not interact with ongoing psychotropics, and remember the medication specific life threatening side effects and take precautions accordingly. Just a simple gist to remember if you have to remember what is to be done. Now, you want to continue. Suppose a patient has come to you and he's, let's say, about a month away from the surgery. Patient is medically stable and everything. He fits everything, and he's at a very high risk of relapse. So you want to continue the medication. So there is no problem in continuing antipsychotics, mood stabilizers, and benzodiazepines, and antipsychotics other than clozapine, as I have discussed. But you still need to individualize the prescription and need to take certain factors into account. So what factors which we need to consider? So here I'm talking about the patient-related factors, the disorder means psychiatric disorders factors, surgical factors, drug factors, and the disease factors. In patient with extreme ages, the pharmacodynamics and pharmacokinetics can be very, very unpredictable, especially those with comorbidities and concomitant medication. You cannot predict the pharmacodynamics and pharmacokinetics, and depending on whatever idea you have about the kind of surgery the patient is going to undergo, you can anticipate what all medications could be introduced, not introduced, and take all these factors into account before you decide about continuing, or I would say, or you decide about switching the medications. So if the risk of relapse is high in terms of psychiatric disorder, consider stopping if other things are unfavorable. So if the risk is low, that person had just one single episode of psychosis about 3 years back, which lasted for 2 months, he is doing well, and the risk of relapse is low, and you're suspecting that there could be a lot of surgery, he's undergoing a cardiac surgery or neurosurgery, it's better that you stop it. Where the risk of relapse is high, continue if other things are manageable, or consider switching if you think you have a better choice, more safer medication. You can consider switching provided you have time in your hand. Then always consider the risk of the antidepressant or the medication withdrawal, which can also lead to something like supersensitivity psychosis or withdrawal catatonia. So you need to keep those things in mind when you're trying to taper and other things. Third is the issue of duration of psychotropic use prior to the considered surgery. So if the person has been receiving, let's say, antidepressant or antipsychotic only for 15 days, 20 days, a month, it's better that you think, rather than entering into a gray zone, it's better to stop if the patient is manageable, not aggressive, not agitated, and so on. But if the duration is longer, you should consider all the factors before you take any decision about continuing or discontinuing. So in terms of psychiatric illness, always consider the clinical stability. And if the patient has received the medication, is on long-term psychotropic, always assess that if he had stopped the medication in the past, what was the time to relapse? Did he or she develop any discontinuation syndrome? Did he or she had any kind of withdrawal symptoms? And if he was also having a comorbid substance, did he had so-called a relapse of substance? And what are his chances of withdrawal? So if the risk of relapse is high, continue the antipsychotics and the mood stabilizers. For antidepressant, I'm keeping that to a very, very individualized decision making. But if you want to continue, this should be informed decision making in collaboration with all the parties involved. And in terms of surgical factors, consider the system involved in the surgery, that if the person is going through GI surgery, neurosurgery, cardiac surgery, keep those factors into mind while deciding about continuing or discontinuing the medication, and what could be the likely time to recover. For suppose somebody is going through cardiac surgery or the neurosurgery, and it's more likely that he is not going to have per oral medication for 5 or 6 days during the very close perioperative period. So then is it required for you to keep on continuing? If the risk of relapse is high, possibly yes. If the risk of relapse is low, it's better that you taper off much before that. And here also putting this, that it's better to take the surgeon's past outcomes depending on his reputation for complications and other things, if you think you can trust your friend, you can take slightly more risk. But if you cannot trust your friend, then you have to be very, very cautious about continuing or not continuing. Don't quote me on this line, but this is what I just want my friends to know. Then what are the drug factors? The type of formulations available that you want to continue a medication which is available in oral, IV, IM, sublingual, liquid form, capsule form. So you have so many formulations, or then you can continue, and there is no problem that nothing becomes a contradiction in from the drug point of view. Then the drug interactions with the anesthetic agent or the any new agent is to be introduced, that needs to be suspected, and how life-threatening side effect or the outcome of this drug interaction could be needs to be kept in mind. And always take the anticholinergic properties of the drugs into account. If the anticholinergic properties are high, the risk of delirium is high, so keep that in mind. And the risk of hypotension, because cardiovascular is something which you don't want to take chances. So if you look at this table, just remember the anticholinergic effect of the drugs which you want to continue, and the orthostatic hypotension and the QTC prolongation. If you understand that, I think you'll be able to decide what to continue and what not to continue. And the other factors which needs to be talked about, if you take a general, as we have discussed, the bleeding risk, hyponatremia, and the drug interaction at the CYP 450 system and QTC and so on, you can take everything into account before you take an informed decision. Now, in terms of serotonin syndrome, again, you may be saying that I've already discussed this, but there I was discussing in terms of when you had no chance to stop it. Here, again, you need to understand, here I'm focusing more from an antipsychotic perspective as well. Some of the antipsychotics like risperidone, olanzapine, ziprasidone, or other drugs like carbamazepine, valproate are also the drugs which can be implicated in development of serotonin syndrome. So you need to take these factors, and the same kind of precautions which we discussed earlier about the medications, you need to keep in mind. Similarly, for QTC prolongation, again, you need to have the informed decision about or discussion about what not to use if you want to continue the drug, and what are the risk factors. And in terms of various antipsychotics, you need to have this clear idea that drugs like thyroidazine, ziprasidone, haloperidol, and some of the other drugs which have a very high QTC prolongation. And one of the drugs which is often so-called not given that much of importance for QTC prolongation is quetiapine. Quetiapine has been reported to cause high levels of QTC prolongation and sudden cardiac death. So at one time, people thought that quetiapine can be used for delirium, but as we have now have started better understanding about the QTC prolongation with quetiapine, at least I try to avoid use of quetiapine for delirium because of the so-called the patient being at a very high risk for developing sudden cardiac death. Then carbamazepine is a very, very potent CYP4 inducer. So remember that if you are using carbamazepine, it can influence the outcomes of drugs like warfarin, nimodipine, felodipine, erythromycin, azithromycin. So these factors need to be considered and discussed. And carbamazepine and valproate can also lead to life-threatening side effects like hyponatremia, agranulocytosis, thrombocytopenia, hyperammonemia, and drugs like buspirone, which again are not talked much about, but can also contribute to serotonin syndrome. And combining valproate with aspirin and warfarin can again lead to drug interaction and increase the risk of bleeding. Benzodiazepines again can have drug interactions with other like opioids and other CNS depressants, and then it can lead to significant sedation and can lead to CNS depression. So if you are using benzodiazepine, discuss this very clearly with the anesthetist that patient is on benzodiazepine and what they need to do, and they need to have the antidote in their hand if the person develops say CNS depression, and they should avoid barbiturate kind of anesthetic agents so that the poor outcome can be avoided. And a lot of psychotropics can have synergistic effect on the brain, like antihistaminics and others can also lead to sedation, and the synergistic effect of QTC prolongation needs to be kept in mind. And the benzodiazepine can prolong the awakening time post surgery. Again, that issue needs to be discussed. And in terms of disease factors, we have discussed these ASA factors, but what we need to understand that There could be antipsychotics when you're trying to use. A person would have tolerated the antipsychotic in the past, but suddenly now, because of the change metabolic parameters, he can still develop sudden hyperglycemia or decay. So you need to keep that in mind, and cannot say that patient has been on antipsychotic for so many years, so many months, so he's not going to develop this. It's not true. The person can become decompensate anytime. Now, in terms of disease factors, the other disease factors which are very, very important are the cardiac risk factors. So that's where all the patients who are undergoing surgery, if you talk to your surgeon friends and anesthetic friends, as I said, I've given you example of ASA, they will also give you findings of other things like what is known as Goldman cardiac risk index. So if the Goldman cardiac risk index is high, it is usually done during the perioperative period, and so if that risk is high, it's better that you have to consider not to continue your psychotropic if you think there could be cardiac risk in your patient. So, and there are other cardiac factors like index scorings like the Lee score. So again, higher Lee score in non-cardiac patient surgeries, please take a careful decision making. To summarize, if you want to continue, consider the patient, disorder, surgical, drug and disease factors, weigh the risk and benefits of continuing. If benefits outweigh the risk, definitely continue, but closely monitor the QTC prolongation, hyponatremia, hematological parameters, electrolytes, RFT, LFT, and sedation. So these need to be very, very closely monitored. Do we need to do anything more? Now, when I said do you need to do anything more, it especially depends on if you have time in your hand, and especially if your patient is consulting you, let's say 15 days, 1 month before surgery, you need to remember that normally patient who undergoes general anesthesia, it's very well known now that they develop post-surgical or post-anesthesia cognitive deficits. So that is where your role comes in, and that is where now we are talking about the prehabilitation programs. If you have to have time in hand, always educate your patient about the nutritional support, the psychological support, the physical support, and medical optimization before surgery so that everything is controlled. Then the surgical outcome would be better, because if patients, if they are under your follow-up, if you can guide them, that helps a lot. And in terms of delirium risk, we talk very clearly about the cognitive rehabilitation, which is a proactive approach that prepares the patient for surgery by optimizing their cognitive functioning before the procedure. And it can involve the cognitive training, stimulation, rehabilitation to enhance the cognitive reserve and potentially mitigate the post-operative cognitive decline. And now we have all the computer-based programs and everything available. And if you go to the developed countries, the patients are told to practice all these things before surgery, which is accepted term is cognitive rehabilitation to reduce the risk of delirium and the post-operative cognitive deficits. So this is something which is in your hand, which you can do. So with this, once we have done the pre-operative part of things, there is one more part which comes in the pre-operative part is you want to start a new medication. You've been consulted, let's for delirium or a new onset psychosis close to surgery or a new onset anxiety or something. So what you can do? So usually you will be consulted for delirium, substance withdrawal, anxiety, and insomnia. So for anxiety and insomnia, low dose benzodiazepine, jet category drugs, melatonin overnight prior to surgery is the common practice. You can use them, but you need to choose a drug which is beneficial. So from here, that point of view, earlier practice was using benzodiazepine, but now people are shifting from benzodiazepine to more to melatonin, because it's not only takes care of sleep, but it also takes care of anxiety, and it also has a better role in prevention of delirium compared to benzodiazepine, which increases the risk of delirium. And alpha 2 adrenoreceptor agonist like dexmedetomidine, which is again commonly used by the anesthetist during the ICU stay of the patient, maybe before the surgery as well. So if they are receiving those medications, choose one of those drugs rather than using benzodiazepine, because now the practice of using benzodiazepine a night prior to surgery is going down significantly. So I've discussed this. And for management of delirium or prevention of delirium, if you have been consulted, try to use the non-pharmacological measures, as I've discussed, the cognitive rehabilitation and other measures for the so-called treatment for so-called what we say as the non-pharmacological measures for delirium. I'm not going to details of that. Or you can choose again drugs like antipsychotics, melatonin, or dexmedetomidine, depending on what is relevant in the patient and what are other relevant clinical factors which are affecting the selection of the drug. But preferably, patient is not agitated, having a lot of sleep disturbance. You can consider starting with melatonin or dexmedetomidine. But agitation is there, that is where the antipsychotic role may come in. For substance withdrawal, again, for alcohol and opioid, it becomes very, very important that use of benzodiazepine and substitution opioid therapy will come into picture, and you need to have certain basic understanding about that. So for alcohol withdrawal, you need to use the symptom trigger benzodiazepine doses rather than front loading, and you need to ensure that the patient is getting adequate dosage of thiamine so that you don't want to complicate the picture. And again, discuss what could be the complication which can arise in terms of airways and respiratory, cardiovascular, neurological, and other systems. How the anesthesiologist surgeon needs to be aware, or how much they are aware. If they are not aware, you can discuss that. Something like it as simple as that: when to intubate the patient, what kind of cannula to use. These all simpler things become very, very important in patients, especially these are the patients who will be undergoing neurosurgery or the orthopedic surgery because they come with trauma. So you should be very, very clear. Now, in terms of choosing the benzodiazepine, lorazepam is something which you need to be preferring to use it. Now, if you don't have time, patient is going to the surgery, always discuss with the anesthetist. This is something which we have developed now as a protocol when we work at PGI, that if possible, try to tell them that can you give propofol to the patient, because propofol is one of the drugs which is used in patient with complicated DT to manage withdrawal. So if that can be done, what happens is that during the surgery and after the surgery, patient takes a lot of time to manifest the symptoms of alcohol withdrawal. So you have a lot of control there, and you can manage your patient. Other options are ketamine and dexmedetomidine. So these are the things which you need to keep in mind when you're having a discussion with your colleagues. For opioids, I think the guidelines for methadone is clear that you need to continue. And for buprenorphine, it is suggested that you need to stop it 24 to 36 hours before surgery, and you can shift them to methadone. And for naltrexone, the recommendations are you need to stop it 72 hours before surgery. And if you are not able to do, then discuss about using a regional analgesia and use of non-opioid kind of stuff during the surgery or during the perioperative period, because with naltrexone there could be again otherwise the problems could arise. And if for other opioids, you can again consider substituting to other opioids, NSAIDs or dexmedetomidine, and the drugs which can be used are the methadone, tramadol, or oxycodone. So those, depending on what is available and what is the preference of the surgeon or the anesthetist, you can discuss that. Now let's move to the post-operative period. We have discussed the pre-operative. In the post-operative period, the issues are restarting of medications or the starting of a new medication. So again, the similar factors will come into picture, and here you need to review the surgical factors. Again, the surgical factors, again, if you go and ask your surgeons friend, they will tell you what is the so-called POSM score for your patient. It's again a scoring system to audit the risk of morbidity and mortality. If the risk of morbidity and mortality is very high, once they have made the scoring system for you, you decide, do you want to enter into that ball game where you can be blamed for mortality or not? You take a decision accordingly. So they rate the so-called, make the score based on the mode of surgery, whether it is elective, duration of surgery, emergency resuscitation required, and so forth. So amount of blood loss and so forth. So you can always ask your surgeon friends about that score. Or if the patient is in ICU after the surgery, ask the ICU clinician what is the Apache score of the patient, which is usually done within 24 hours of admission. Higher the Apache score, again the higher risk of mortality. Again, keep that in mind. And similarly, other alternative is the SOFA score. So here again, the higher the scores, higher the risk of mortality. So again, remember when you're going and reviewing the treatment records of your patients, please review these scores. This will give you some idea where at what level you are. Otherwise, just taking a blanket decision may not be a good thing to do. And we have discussed the cardiac risk scores. Then what is the current level of hemodynamic stability? If patient is hemodynamically stable, at least I would say for 24 to 48 hours, that is where you need to consider prescribing. Otherwise, during until a patient is not agitated, not kicking and everything, rethink about prescribing, especially other than for delirium. You need to be very, very cautious. And again, we have discussed the patient's past history in terms of when we are discussing the pre-operative. So, can the person tolerate the so-called post not taking the medication for a few days? If the history suggests that he can do well without the medication for some days, it's fine not to start. And always keep on assessing the severity of symptoms and what is going to happen if you want to prescribe the patient is agitated or if the patient is symptomatic, what could be the impact of patient symptom on the post-surgical outcome. Suppose patient becomes agitated, pulls out the tubes, pulls out the drainage and everything, you're suspecting that all those can happen, it's better to prescribe. And so, and overall recovery. If the patient is not, suppose patient has depression, and because you are not treating depression, patient is not cooperative for the rehabilitation process, it's better to prescribe. So always weigh the risk of treating with psychotropics versus not treating with psychotropics and take an informed decision by considering all these factors into account. Always remember the drug interaction and the side effects as well. So when to start? When patient is medically stable, the risk of any surgical or medical complications are minimal. Patient is able to take the oral medication because most of the psychotropics are given orally, and electrolyte and coagulation parameters are within the normal limit, including the renal function test and the hepatic renal functions. And when you are introducing the drugs, always introduce as monotherapy in the low dose, and rather than prescribing on a regular basis, always consider can I manage the condition with SOS medication or do I need a regular medication? So all this has to be again individualized. So in terms of selection of drugs, again, formulation, side effects and other things needs to be taken into account. Now coming to one of the important aspects is the GI surgery. This is something which you will see a lot of patients undergoing bariatric surgery and the GI surgery. And so what we need to remember, majority of the psychotropics are absorbed through the stomach and the upper one third of the small intestine. And if the person has undergone the gut resection, you need to be very, very careful that it's going to affect the absorption of the different drugs. And this is where you need to understand that people, those who are on SSRI, SNRI, NASA and other things, especially the SSRIs, they will require increasing their doses of antidepressant to manage the same condition which we were managing beforehand. And for SNRIs, to overcome some of these complications, you may have to shift from extended so-called extended release formulations. You have to shift them to a intermediate or the so-called immediate release formulations because you want the absorption to increase. So because the surface areas and everything has changed, so extended release may not be a good thing to consider. And again, you have to make a plan before surgery. What are you going to do? Ensure that patient modified prescriptions and other things, care plan has been made. Nutritional status, because nutrition can also again change, so fluid and other things will change. And if you want to change to an immediate formulation, liquid formulation, orally dissolving formulation, all these factors need to be individualized for your patient rather than again having a straight jacket answers for this. So antipsychotic absorption can also be lower compared to the pre-surgery levels, and because with bariatric surgery there can be sudden lot of loss of weight, so lithium levels again can drastically increase, so that needs to be kept in mind. And for sleep disturbances, I'm just rushing through. You can consider drugs like melatonin, zolpidem, benzodiazepine if you want to prescribe, but before that try non-pharmacological measures and try to understand are there environmental factors which are actually leading to sleep disturbance, and if you can correct them, that would be the best thing. For delirium, we have discussed the medication. For The alcohol withdrawal delirium, again lorazepam, and for other drugs, for other non so-called metabolic delirium, consider the drugs depending on how much is the risk for QTC prolongation. For clozapine, if it has been stopped, remember, if it has been stopped for more than 48 hours, you may have to retitrate. Some people say if it has been stopped for more than 72 hours, you have to retitrate, but you need to again remember that. And if there is a concerns about the enteral absorption and person has undergone GI surgery, the risk of paralytic ileus and everything needs to be considered before you think of restarting clozapine. And lithium, again, better to restart only after some time, once everything is under control, and you should monitor the lithium levels very closely. So to conclude, we need to remember that one size does not fit all. We need to have individualized management. You need to have good communication with the patient, and at the same time good collaboration with the surgeon and anesthetist, and look at the interaction of drug and drug disease. And when you are trying to decide about the use of drugs, you need to be very clear that in general, there's an evolving consensus that majority of the psychotropics can be safely used during the perioperative period, provided there is a clarity of what other drugs to use and not to use, and what are the physical parameters of the patient. And the basic aim is to reduce the negative outcomes in terms of morbidity and mortality, and for clinicians in terms of litigation and having interpersonal relationship issues with your surgeon and an anesthetist friend if something happens. So just I'm rushing through. If you want to see type of surgery, type of anesthesia, physical health status, all things needs to be taken into account, and consider the various factors in terms of the risk which are involved. And just remember, if you want to remember, clozapine needs to be stopped, lithium needs to be stopped, MAO inhibitors needs to be stopped. Other things are individual decisions. Okay. Yeah. Thank you.
Thank you so much, sir. I think it was such a knowledge addition that it will be one of the most watched videos on our channel now. So
Thank you.
very practical and very useful tips. Thank you so much, along with the references.
Yeah.
So,
Thank you.
yes, sir. Over to
Yeah.
chairpersons now for their remarks. Then we go to question answer.
Thank you, Dr. Grover, for the excellent presentation. And definitely, you nicely discussed this issue and many of the queries which are coming in our mind. And you answered most of those queries. But still, we have many questions with us. And can I repeat questions here, or you are already having this?
No,
These
sir,
questions?
sir, please, you can sir, take the questions.
You can also
Okay.
take, or Grover sir also has access.
Okay,
Okay.
I have an access, but if you want to read, it's fine. Otherwise, I can read and answer.
Okay. Dr. Roop Sidana, he has asked how much is the risk of increase of bleeding if the patients are on SSRI, particularly the sertraline. I think probably
Okay.
you have answered it.
See,
But yes.
the risk of bleeding is, when we say that patient is only on sertraline, the risk of bleeding is more than what you see in general population. But when it is combined with a NSAID or aspirin, the risk is very high. So
Okay.
remember that the risk almost doubles, triples depending on the age and other concomitant medications. So there is no one straight answer. That's what I would possibly end up saying to many of the questions. Yes.
Okay. Dr. Bojek, he want what is the rule of half and wash half life to discontinue or restart treatment?
Okay. So normally when we say that whenever the patient is receiving a medication, if we have to stop before the surgery, the medication to clear from the system, you at least require 5 half-lives. So if you're deciding about stopping a medication before the surgery, keep that in mind, that you start tapering and there's a gap of 5 half-lives before the surgery and when you stop the medication. So that fact needs to be kept in mind. Yep.
Dr. Pramila wants to know about if the patient is on anti-Parkinsonian drugs, what should be advised pre-operatively?
I think I've answered this question, that in the preoperative phase, if you can stop the anti-Parkinsonian agents because it increases the risk of delirium, it is better. If you cannot, discuss that possible risk with the treating team. So if whenever possible, stop it. But if you're stopping it, and again, if you're trying to abruptly stop, remember that patient will go into withdrawal kind of a catatonia, which is known as Parkinson hyperpyrexia syndrome, and that may be confused with sepsis and other things. So
Yeah.
that kind of a knowledge of psychopharmacology is very, very important when you're going for a discussion with your colleagues.
Dr. Suhash, he wants to know if the patient is suffering from dementia and he is on donepezil or the rivastigmine, then what should be done about?
Again, some of these drugs, the donepezil, rivastigmine, can be continued. We do not have much of data for this. So the basic understanding is that you can continue. They also, some of these have been reported to decrease the risk of delirium. In that scenario, the usual recommendation is don't disrupt.
Okay. And Dr. Rahul Rajiv, he wants to know if the patient is on naltrexone planned for the surgery, and if the anesthetist says that he wants to use opioid for the analgesia, then what will be your
I
stance
have
on this?
answered that, sir. I have answered that question.
You have answered. And there
Yeah.
are many other in chat box. There are many praise about you also, and many people have appreciated your this presentation. And apart from that, there are a few more questions. When the
Yeah.
patient is highly suicidal and having lag bone fracture due to fall from the height, and the surgeon is asking for the fitness, how can we proceed, sir?
Can you repeat the question, sir?
If the patient is highly suicidal and having a lag bone fracture due to fall from height, and the
Yeah.
surgeon is asking for fitness, how can we proceed, sir?
See, as far as fitness for surgery, I interpret this as
And
fitness for
simultaneously, the patient is alcohol intoxication state taken from emergency surgery. How to decide on fitness?
that's what I'm saying.
Hmm.
I've said that when patient is alcohol intoxicated, you need to wait till the patient is coming out of the intoxication. But in terms of, let's say, psychiatric condition, if he just has suicidality or anything, it's not a contraindication for undergoing surgery. Person undergoing alcohol withdrawal, it's not a contraindication for undergoing surgery. Person in delirium, it's not a contraindication for undergoing surgery. So there is no particular psychiatric condition which contradict or is a contraindication to undergo surgery, that you need to postpone the surgery. Please understand that. Again, postponing the surgery, you have to take the responsibility if there is a negative outcome later on. So be very clear about this fact. Tell that these are the risk and benefit. Take the informed consent from the patient and the family. You explain them as surgeon. My job is I can only give you my opinion. From my opinion, there is no contraindication that you cannot undertake the patient for surgery. But these are the factors which needs to be covered in the informed consent.
Okay. And Dr. Rahul wants to know if the patient is on gabapentin or the pregabalin, then what to do?
Okay. So again, depending on the receptor profile and other things, you have to decide about these medications. Some of these medications do not have a very, very clear consensus. In terms of, I have given you a broad outline for anti-epileptics, they can be continued. So taking that into account, I am just extrapolating that these can be continued. But if you want, just write a mail. I can again check the literature and give you the specific answers for these drugs.
Uma Maheshwari wants to know if the patient is having nicotine craving in the perioperative period, how to manage, sir?
Patch, inhaler. Nowadays, patch and inhalers are available. Use them as much as you want.
And if the patient is on long-acting parenteral antipsychotic, how do we manage?
Okay. So continuation of any antipsychotic is not a contraindication for surgery. I've made this very, very clear to everyone. It's only clozapine which is a major concern. So if his patient is on a depot, just inform that patient is on a depot, and remember that there are no factors which can lead to, like serotonin syndrome, cannot lead to NMS, QTC prolongation. All these factors will come into picture, but these needs to be discussed because the depot is already in. You cannot take the depot out.
Okay. Then there are a few comments also. Sir, for SSRI, is not better to stop before operation, at least before 1 week, as it is causing increased bleeding time? I think it's okay.
I have answered that there is no
Yeah.
consensus. But a new consensus says that don't stop it. You can continue, but I've said that not a straight jacket. Remember that you have to take other factors into account.
There is one more question from Raj Lakshmi. If the patient is planned, endoscopic bending for the hematemesis in delirium and elevated amylase and LDH, how to proceed for withdrawal management call over the called for, sir?
Very simple. Patient is not undergoing GA, and usually for endoscopic banding and everything, they use sedatives. And as I said, you can discuss what kind of sedation they are going to use. Are they happy to use benzodiazepine or propofol? Remember those similar kind of, or dexmedetomidine. You can always discuss with them, and whatever they want to prefer, you can just tell them these are the. I would prefer you use one of these. So accordingly, you can have a discussion with the surgeon and the anesthetist.
Dr. RC wants to know what are the practical considerations to absolutely stop.
Okay. I said that ASA 5-6 stop. Absolute contraindication to continue psychotropics.
Thank you, Dr. Grover, for answering all these queries which has come in this chat box, and thank you again. Now proceed further.
So, sir, I'll just have a small comment, sir. Very excellent presentation, and sir has answered most of the questions and whatever the queries which we had in our mind. Just to add on, this is a suggestion to all our psychiatrists where we had gone to concentration rise and psychiatry. Make sure that we write legibly so that the surgeon and the other people understands that. Second important thing is what sir has mentioned is that we have to discuss with the anesthetist, surgeon, also the staff nurse. So this is very important, which we generally don't do that. We have to discuss about the patient and what the medications and other things. Excellent presentation, sir. And one more important thing, be preferable to be in monotherapy, especially when we are in the outside consulting CL psychiatry, sir. Thank you, sir. Over to the chairperson and the members, sir. Other members.
Thank you, sir. Thank you, sir. Any questions are left, Vishal, in the chat box? Amrit?
I think sir ने सारे ले ही लिए हैं. Dr. Batra sir has already covered.
Yeah, Batra sir एकदम
enthusiastically.
Enthusiastically covered the marathon.
Marathon,
So I think yeah, the information is quite a bit.
Amrit, you are muted. Amrit, you are muted.
रोवर सर ने सारा क्वेश्चन तो ले लिया और ऑस्ट्रेलिया में भी 1 बज गया होगा मुझे लगता है. कितना टाइम हुआ है सर? You are muted now.
1:45.
बाप रे बाप. I think
Okay. So I think we have covered all the questions. I think the thing is all the things are now there on the platter at one place. So we just have to go through and we have to update ourselves and we take a reference from it whenever needed. So thank you so much. Any comments from co-moderators? Then otherwise we can start ending the session. Amrit and Vishal?
No. I think it's a great presentation.
I think it was a very good presentation. I think Dr. Sandeep has covered a lot of topic, a lot of different scenarios. जो हम सोचते भी नहीं हैं.
Scenarios.
It's very nice. It's not just one surgery, multiple surgeries, and that has helped made our job much easier. So thank you, Dr. Sandeep.
Thank you.
Thank you for doing that so late.
Participation. Yeah, thank you.
Amrit, over to you for Thanksgiving.
So thank you, Grover sir. It's night 2:00, you know, and you are showing so much energy. It was comprehensive, case wise. You know, these are the situations which we get into. You know, so it was very brilliantly covered. Lalit sir took a lot of questions. Dr. Arun sir also summarized very well, and thankfully, you know, we ended in time also, and we had a great participation today. I think more than, you know, the peak was 230. That is huge. So thank you again, Grover sir.
Yeah,
thank you to the chairpersons, and thank you to. We are missing Shobhit today, but Dr. Vishal and Dr. Aleem are brilliant as always. Dr. Tofan sir is also not there. Thank you. Good night. Meet you
Thank
again.
you.
Next
Thank
Thursday,
you.
we are taking a break, Alim.
Yeah,
For
Dr.
midship,
Alim,
we are taking a break.
Next
Dr.
Thursday, we're taking a
Alim,
break. Next Thursday,
yeah,
we're taking a
Yes,
Dr.
break.
sir.
Alim,
Yes, sir.
some of the people are asking in the PPT, just tell them that everything is available on your YouTube channel. So just anybody who wants,
Yeah. So
they can
yeah,
watch.
Just
they
put the
can.
link, sir. Put the link on the chat box.
Vishal, you can put the link of the YouTube.
Just put the link.
Grover boss, someone is asking for your email, so you can also type your email, please,
Okay, my email is here. Okay, I'll send that.
in the chat box. So we had to stop a few persons from joining today because
Hackers.
of the,
Alim is
because the
happy because
hackers.
he managed to stop few hackers.
I had to miss much of your presentation because I was managing the hackers today. So, but thankfully we were able to do that.
I think
Okay.
Australia say other people are also planning to join.
Thank you,
Okay,
sir.
sir.
Thank you
Thank
so
you.
much.
Thank you all.
Thank you, Arun
Thank you.
sir, Lalit sir, Sandeep sir.
Yeah. Good night.
Thank you,
Very
sir.
nice presentation. Thank you.
Okay,
Ending the
good
meeting
night.
now.
Good
Ending
night.
the meeting now. Bye bye to the hackers also.
Bye.